Dear viewers, today I'm going to talk about complications related to diabetes and when we need to screen for them, how we need to screen for them, and why we should screen for these complications. So, first of all, coming to complications, there are two types of complications of diabetes. So, one is called a macrovascular complication, another one is a microvascular complication. So, microvascular complications are closely tied to the duration of diabetes and the control of diabetes. Macrovascular complications, not so much actually. So, most often when we talk about complications of diabetes, we tend to think more in terms of microvascular complication. So, what is microvascular complication? So, this refers to damage to small blood vessels which happens due to the high blood glucose level. In fact, the extent of damage is directly proportional to the amount of blood glucose increase and the duration of blood glucose increase. So, for example, if someone has even slightly elevated blood glucose level but it lasts for 10-15 years, they can land up with microvascular complication. Or on the opposite side, if they have very high blood glucose levels for even a few years, say maybe 4-5 years also, they can get a microvascular complication. And microvascular complication also is associated with age and certain other conditions. So for example, if you're older, you tend to get more microvascular complication than when you're younger. So even children, very young children with type 1 diabetes, since they are in the growing age, they do not experience so much microvascular complication like adults would. So, for example, a type 1 diabetes patient who gets type 1 diabetes at 50 years will get microvascular complication much faster than a young child who gets the type 1 diabetes at the age of 5. So, these are key differences. These are the key points as far as microvascular complications is concerned. So, when a doctor looks at a patient with type 1 or type 2 diabetes, they are mainly looking to see whether there are any microvascular complication affecting the nerve, which is called a diabetic neuropathy. Diabetic neuropathy is a form of microvascular complication. Second form of microvascular complication is retinopathy, or the retina being affected by the diabetes. And the third form of complication is diabetic nephropathy, or involvement of the kidney by the microvascular complication. There are key differences between these three varieties of complication. Diabetic neuropathy is highly symptomatic in the sense that patients experience a lot of symptoms due to neuropathy. Their foot goes numb, they may have burning sensation or pain all the time, they may sometimes have cramping. So this can usually it involves the feet and then gradually moves up the body. And when the symptoms reach up to the knee, then your hands also can get affected. But there are other varieties of neuropathy also which can start suddenly. These are called mononeuropathies. Sometimes patients with type 2 and type 1 diabetes are more prone for compression neuropathies also, like carpal tunnel syndrome is more common in type 2 and type 1 diabetes. So this is as far as the symptoms of neuropathy is concerned. Contrary to this, retinopathy and nephropathy are extremely silent complications, and one need to look for this complication rather than ask the patient whether they have any symptoms, because the first symptom that can be produced in diabetic retinopathy can be directly loss of vision, and the first symptom that can be produced in kidney complication can be kidney failure where nothing can be done. So it's important to screen for all complications. And when it comes to neuropathy, not all neuropathy is the same. So, for example, there are patients who may have a lot of burning sensation, pain, etc. But their sensation may be normal actually. So, these individuals are not prone for ulceration of the feet actually. But there are patients who may not have much of burning sensation or pain. Their complaints may be very less, but their sensation may be completely lost in the legs. So, these patients would not complain anything to you. So this is one of the key reasons why we need to screen for neuropathy also. So we understood what are microvascular complications when they occur. So usually when you look at microvascular complication, they occur say 5 to 10 years after the onset of diabetes. So when it comes to type 1 diabetes, there is a key distance between the time. So the time of onset of diabetes is very clearly known. So when you are admitted with diabetic ketoacidosis, you have very high symptoms. You have you're passing a lot of urine, you're lost weight, etc., and you are sick basically, and the time of onset is very clearly known in type 1 diabetes. But when it comes to type 2 diabetes, we really do not know the time of onset, because the patient might have had diabetes for several years before diagnosis. So in any patient with type 1 diabetes, at least after 5 years we start screening for microvascular complication. But in type 2 diabetes, irrespective of the time of diagnosis, we straight away screen for all microvascular complications. So what are these screening procedures? First, let me come to retinopathy. For retinopathy, we need to do the most important thing is actually a fundus examination or a retina examination. The retina examination will tell us whether there are any microaneurysms or blood leakage in the back of your eye. So microaneurysm can be easily spotted by a fundus photography, and nowadays fundus photography facility is available in majority of diabetes centers. It's available in Magna also. It's a very simple procedure. We can do it with dilatation eye drops or without dilatation eye drops. So both can be done. So depending on the size of your pupil and the clarity of images, we can do it with or without the eye drops. And the images can then be interpreted by a retina surgeon or by your diabetes doctor to see whether there is any retina involvement due to diabetes. Majority of patients would have a normal retina report. I would say almost 98% would have a normal retina report. Only 1 or 2% tend to have retinopathy. And how often this needs to be done? We need to do this every year once. So, and apart from this, if you can meet a retina doctor directly and get the retina examination done, that's also best. This is the screening for retinopathy. So what happens, what follow-up action is to be done? See, if we find out of these 100 patients we screen, if 1 or 2 people have a retinopathy, we'll ask them to meet a retina specialist who can assess whether any laser treatment is required. And once retinopathy has been recognized, one need to follow up these patients every 3 to 6 months, depending on the severity of retinopathy, to see whether it is progressing, whether it is coming down, or whether any intervention is required. And the act of screening itself can save vision, because there is a stage of retinopathy called severe non-proliferative diabetic retinopathy or proliferative diabetic retinopathy, where the vision can be threatened. So when the vision is at threat, so the ophthalmologist does something called the laser treatment of the microaneurysms. So leaving the central part of the retina, the peripheral part of the retina, we can burn some holes using laser and prevent the retinopathy from progressing. So this is a treatment directly for retinopathy, apart from the treatment for diabetes. Of course, if you have diabetes and if you treat the diabetes, the retinopathy does improve over a period of time. But when the retinopathy is already set in, additional treatments are required. So retinopathy screening is very important. So coming to the second complication, diabetic nephropathy. So what all tests to be done every year? Every year we should perform a serum creatinine, and from that calculate something called the estimated GFR. So the estimated GFR is calculated using a formula, and you can enter the creatinine value and the patient's age in an online calculator, and it gives us an estimated GFR. So eGFR and a creatinine to be measured every year once. This is a blood test. But apart from this, we also perform something called the urine albumin creatinine ratio. So this can be done, it is usually done randomly on any sample. It need not be a fasting sample, it need not be a timed sample. So people have done research looking at various ways in which to collect the urine, but typically any random urine sample is sufficient for us to screen for albumin excretion. And albumin excretion tells us that the blood vessels in the kidney are leaky and little bit of albumin is escaping into the urine. And if we detect the kidney damage at this stage, giving various medication helps us in preventing the progression to the next stage. So microalbuminuria is a stage when the urine albumin level is between 30 milligram per liter to 300 milligram per liter. If we give various medications like ACE inhibitor, ARB, SGLT2 inhibitor, so this class of drugs, we can prevent the progression of albuminuria. So this is on top of your glucose control. Of course, if you control glucose in any patient, the microalbuminuria would improve. But in addition, certain medication can help. In addition to the ACE inhibitor and ARB, we can also give a novel drug called Finerenone. This has also been shown to prevent the progression of albuminuria to higher stages and to prevent kidney failure. So this is with regards to diabetic nephropathy and screening, and both the diabetic retinopathy and nephropathy screening has to be done once a year. So coming to neuropathy. So what test we do for diabetic neuropathy? So we can do diabetic neuropathy screening. We can do a simple test like a monofilament, 10 gram monofilament test can be done. This is basically done to check the touch sensation, the protective sensation. So, and another test that we do is a vibration perception threshold. So we give a vibration to the leg and check the millivolts at which the vibration is perceived. So usually any millivolts more than 25 millivolts would mean that the patient is requiring a large amount of energy to perceive. So the sensitivity of the leg is a little less actually. So this indicates the onset of neuropathy, and loss of 10 gram monofilament also indicates a loss of protective sensation. Apart from that, we can check for temperature sensation also. In Magna, we have a facility to check cold and hot temperature, vibration perception, as well as monofilament using standardized test instruments. So using these instruments, we can clearly predict who is the person who is having neuropathy. So what is the fun in identifying a patient with neuropathy? So if you've been detected to have a loss of protective sensation, so you must examine your feet daily to check whether there is any ulcer that has formed or any infection is there. Sometimes what happens is you may have a small thorn stuck into your leg and you may not realize that it's even there. So systematic examination of a leg, which is where the sensation is lost, is very important in preventing any further damage to the foot. So this is with regard to the microvascular screening to protect the feet is concerned. So coming to macrovascular complication or large vessel complication, one macrovascular complication that is unique to diabetes is peripheral vascular disease or PVD. It tends to affect the aorta and the branches of aorta. So aorta is basically a big main pipe of blood that carries blood in our body. It divides into two vessels which supply either leg, called the common iliac arteries. So the atherosclerosis can form aorta and in the common iliac artery branches, and therefore it can reduce blood flow to the legs. So in order to find out how much is the blood flow to the legs, we use a method called the ankle brachial index. So where we compare the blood pressure in the lower limbs with the blood pressure in the upper limbs. So if the blood pressure in the lower limb is lower than the blood pressure in the upper limb, that is less than 1, it's a cause of concern. If it is less than 0.8, definitely there is a peripheral vascular disease. Many a times patients may not have symptoms due to peripheral vascular disease. So they may not have any pain while walking because of neuropathy. So patients with type 2 diabetes who have peripheral vascular disease and neuropathy, even when they walk, they may not have pain. Whereas people without type 2 diabetes who are having peripheral vascular disease will become symptomatic much more faster. So screening is very important in anybody over the age of 45 and having type 2 diabetes to look for peripheral vascular disease. This facility is also available in Magna. We do it regularly for all our patients. And once you're detected with peripheral vascular disease, what else do you do? If you're asymptomatic, you don't have any symptoms, we need to look at lowering the cholesterol, say below an aggressive value of below 50 milligram per deciliter for LDL, and this will prevent progression of the atherosclerosis and may even in fact regress the atherosclerosis in patients. So it's a vital step to screen for complications of peripheral vascular disease. So apart from this, there are other vascular beds also. Is it only the lower limb which we screen for? There are other vascular beds like the brain and the heart, but that's usually dealt with by neurologists and cardiologists. But typically we elicit symptoms, whether while walking fast or climbing stair, do you feel breathless, etc. If such symptoms are there, we refer the patient to the cardiologist. So sometimes if there is a carotid vascular disease or the blood vessels supplying to the brain and to the eye are blocked, so patients can have sudden loss of memory or sudden loss of speech, such symptoms. So then we refer the patient to the neurologist for further evaluation.